Good afternoon, and thank you for joining the RLS Foundation's webinar titled Drug Holiday, What to Expect. My name is Carla Diezenkowski. I'm the Executive Director at the RLS Foundation. The surge in the use of web-based programs during the COVID-19 health crisis has created a strain on the system. If you are experiencing technical difficulties, switch to the audio portion of the program as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Early will answer as many questions as time allows at the conclusion of this presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal of our website. If you are not a Foundation member and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Christopher Early, is a professor of neurology at Johns Hopkins School of Medicine, where he's also director of the Johns Hopkins Center for Restless Legs, which is a certified RLS Foundation Quality Care Center. Dr. Early is board certified in internal medicine, neurology, and sleep medicine. His interests include RLS and sleep medicine, specifically the pathophysiology of RLS and revealing the value of various treatments. He is chair of the Foundation's Scientific and Medical Advisory Board. He's also an active member on the Research Grant Committee and Revised Treatment Consensus Guideline Committee. Dr. Early, we thank you for sharing your time and expertise with us today, and I now invite you to begin your presentation.
Good afternoon, everybody. So today's presentation will be sort of directed towards what is referred to as drug holiday, which has a lot more different facets to it. And I'll talk about some of the facets and the reasons why one might want to take a holiday. I suspect many of you have it in mind that the only reason to take a drug holiday is if you have drug-induced augmentation, which is definitely one of the reasons, but there are several other reasons, and I will go through this. Some explanations, probably give you some examples that will hopefully be useful to you. So there are three common reasons to consider a drug holiday. One may say that the medication is working, but do I still need it? Second, medication seems to be working, but I really don't want to be on it. And third, I'm having problems with the current medications. What do I do? So let's start with the first. If you see, if you're on a medication and you want to ask the question, is it still necessary? Obviously, there's a couple of things you have to consider. One of the most, I think, important data sets is a study that we did before the Ropinirole or Requip commercials came on TV. Prior to that time, approximately of the nearly 1,200 people we interviewed, only about 20% actually were on medications. And so a vast majority of people were not on medications. Many have tried, but couldn't find one that worked, or in fact, many people didn't realize there were treatment options. When you look at populations of people over time that have not been on medications, what you see is often symptoms come and go. They can come for a year, go for a while, come back again. They can come for 10 years and go away, and sometimes not come back, sometimes come back. So there's a lot of variability in symptoms. Sometimes symptoms may flare up for a few months. Once Requip was introduced to the general market as the important godsend that was going to relieve you of your symptoms, everyone rushed out there. It is estimated probably less than 15% of people with RLS nowadays actually are not on medications. The problem is that many patients will have symptoms and they flare up for a few months. when you know there's an immediate answer, you rush to your doctor, he puts you on the medication, and sometimes that medication will perpetuate the problem or at least keep you asymptomatic and not make you realize that the symptoms have long disappeared and maybe you don't need to be on the medication. There are potential triggers and aggravants that may be reduced or eliminated. So if there are a couple. So for example, iron deficiency, your symptoms flare up because of iron deficiency, you go on medications, you treat the iron deficiency, do you still need to be on the medication? Poor sleep, one of the single biggest contributing factors to variations and aggravation of RLS symptoms is poor sleep quality. The worse your sleep gets, the worse the RLS is going to get. The better you improve your sleep, the better you can improve the RLS symptoms. And so in some patients who have definable sleep problems like sleep apnea, treating the sleep apnea may bring about significant improvements in the RLS that you don't need to be on medications. Patients' work hours. Some people in this vicinity would get up at 4 or 5 o'clock in the morning in order to travel an hour and a half down to Washington, D.C. They are not 4 or 5 o'clock in the morning person. With the pandemic, as it transpired, many of these people are able to sleep in on their regular hours, are now getting up at 7 or 8 o'clock and get a better night's sleep. Some of my patients have been able to reduce their medications because they've improved their total sleep quality. Pain conditions. Any pain involving the legs, muscle pain, arthritic pain, neuropathic pain is going to aggravate the RLS and therefore lower your threshold and may push you to seek treatment or increase treatment. Reversible causes, knee replacement. Pain's not there anymore. Is it possible that you need as much or need any at all as far as treatment options for the rest of the legs? Medications. Notably, the antidepressants will aggravate RLS symptoms, and therefore, if the patient is treated for the RLS and they were on an antidepressant and at the time couldn't come off the antidepressant, maybe it's time to test whether or not they need to be on the medication. Pregnancy. Approximately 20% of women during their last trimester of pregnancy will develop new onset RLS symptoms. And then after delivery, the symptoms will go away, and the majority of people, but it may take weeks and months. At that point in time, the patient may seek help with treatment and not realize symptoms are likely to go away on their own, and therefore it's sometimes worth investing time and discovery as to whether or not the medication needs to be continued if they're long past the issue of the pregnancy. So this is an 82-year-old woman, RLS for about 22 years. She was on gabapentin, doing great. No side effects, no symptoms while on treatment. Her current dose was 1,800 milligrams at night. Her ferritin was in the relatively normal range, and she was unable to refill her prescription on time. This was a bit of a snafu. She had gone to Europe and she miscalculated the medications. Her flight got canceled, so she got delayed coming back into the States and essentially was off medications completely for 6 days. At the end of the 6 days, however, she discovered that she only had an occasional symptom. They were basically a couple times per week, and they were relatively minimal. So in fact, the drug holiday proved to be of value to her. Now she's on small dose of hydrocodone taken as needed, which is maybe once, maybe twice a week. This is a 70-year-old man, 12 years of symptoms. He was on ropinirole. The RLS symptoms were now throughout the day. He had significant daytime hypersomnia, another consequence of the chronic use of the dopamine agonists. His ferritin was in normal range. He was on venlafaxine. Venlafaxine is an antidepressant. Its brand name is Effexor. It is in the category of agents called SNRIs, which is it blocks noradrenaline and serotonin. It tends to be slightly activating. It's a good antidepressant, don't get me wrong. Basically, he'd been on the antidepressants for about 12 years, which was approximately the duration of time he actually had his symptoms of RLS. So he was taken off the ropinirole as a process of detoxing him off of the drug because he had some augmentation, clearly. And at the end of the 11 days off of the ropinirole, he ended up with just nightly symptoms. And we had a discussion, and I advised him about coming off the venlafaxine to see if he really needed to, whether or not it was contributing, and whether or not he really needed to have it. Since he'd been on the antidepressant for 12 years, and the issues that got him on the antidepressant, some personal issues, had since long resolved. 5 days off the venlafaxine, he had 0 symptoms. And so here is a double drug holiday. Obviously, one to get him off of the ropinirole because of the augmentation, and the other to decide whether or not the offending agent was relevant to his symptoms. 64-year-old man, 6 years, blood donor, and on non-steroidal anti-inflammatories. Started on pramipexole up to 0.25 milligrams 6 years prior to me seeing him. Ferritin was 35, so he had a low iron level. He received an IV iron infusion from me. And then he came back to me after the iron infusion, and I tapered him off the pramipexole, my standard protocol, which at the end of this, or near the end of this presentation, I will discuss. Basically, he was drug-free for 11 days, and at the end of that period of drug-free period, he was asymptomatic. Patient returns about every 2 years, calls me, tells me his symptoms are back. I check his iron levels, and the iron levels, not surprisingly, are low again. I give him another iron infusion, and he's good for another 2 years. So the next question is, do I really want to be on this drug? And I know that sounds hard to believe for many of you. I'm sure many of you have entertained the idea, but I'm sure it's quickly short-circuited by the concept if you weren't on the drug, what could you do? But there are a small number of people who just do not want to be on a drug. It is almost like a belief to them that being on drugs is an issue, and therefore that's a question that they have. The question is, do I want to be on this drug every day for the rest of my life? That's sort of how they phrase it. That's sort of how they see it. They feel, I guess, dependent, things like that, but that's their perspective, and I have no problems with that. So some people decide to go off the medications because they don't want to be on it. So that's another reason to do the drug holiday, in part to come to some level of symptom decisions about the symptoms and what you can or can't live with. So this patient had symptoms 55 years by the time I saw him, actually. For years, he had a bicycle basically bolted to the floor right next to his bed. And he basically, for the last 40 years, would ride the bicycle for about 20 minutes at a certain amount of ergs or energy, get into bed, sleep for 3.5 hours. It would wake him up again. He'd do another 20 plus minutes on the bicycle and then go back to bed again. I have people doing, again, various different things, not necessarily bicycle. There's the Peloton is one of the things people do. There's a couple of different things. Basically, he was enticed by the advertisement of the Requip advertisement, whatever, 18 years ago, I think it came out. I put him on Mirapex. He stabilized with 0.5 milligrams, which is my maximum dose. Remained on that for about 8 years. Medication worked, but in his mind's eye, he just really didn't want to be on the medication anymore. I'm not sure, he just didn't feel right about it from a taking drug point of view, or it just didn't make him feel right. But in the end, his decision at that period of time, we talked about it over the years, was to stop it, and he stopped it. So I tapered him off successfully, without too much of the problems, and then he went through the standard 2 weeks of drug-free baseline. went back to having nightly bedtime symptoms, and he returned to his bedside bicycle. And he had been doing that for the next, he's in his 90s now, so a while anyway. So the next and third element is the most common reason for considering coming off the medications or drug holiday. And so you have problems with the medication with chronic use. So the usual problems are side effects. And so the side effects include daytime hypersomnia, depression, nausea and vomiting with the dopamine agonists, nausea and vomiting, nasal fluid retention. The alpha-2 delta agents are going to be a significant fluid weight gain, increased appetite, sedation. Methadone is going to be constipation, sedation, depression, or sedation / sleepiness. And then tolerance, which is going to be, again, not uncommon with the alpha-2 delta agents, less common with the opiates. Augmentation, obviously, with the dopamine agonists. Occasional financial, which is becoming a bigger problem because insurance companies are paying for less and less. And many patients, unfortunately, have been on the drug doing well for years, and then their insurance company refused to pay for it. And therefore, we have problems of coming off of medications and having to deal with issues with obviously sometimes deciding what alternatives to consider that the insurance will pay for. So let's talk about some cases. Okay, so more or less 15 years, methadone 10 milligrams times 5 years. So doing well. The only problem was she had significant daytime sleepiness, almost a narcolepsy-like condition. Fine, as long as she stayed busy and active, sitting down. She does nod off middle of phone calls, conversations would nod off. Her ferritin was 110, so no specific treatment for that. So I tapered her off the methadone. My standard period of time off of medications are usually about 12 to 14 days for most of the medications in general. So I put her through that. Again, for those who've had to get off of dopamine agonists, coming off of the alpha-2 delta agents, and the methadone is tough, but it's not anywhere close to what happens when you have to come off of dopamine agonists. So essentially, at the end of that period of time, she had evening symptoms still. So we returned to methadone. We actually ended up back at a lower dose at 7.5, but she had no sleepiness. And so the point is, sometimes the side effects, by doing a drug holiday, you can get back on a low dose and maybe get another 5 years out of it before the side effects show up again. So this woman had history for 37 years. She'd been on Requip for 12 years and severely augmented. Her current dose was 4 milligrams. Ferritin was 113. So we tapered her off doing the standard, my standard anyway, protocol for drug detoxification. She was 11 days drug-free, symptoms mild, bedtime symptoms maybe 3, maybe 4 nights out of 7, so not every night, and they're relatively mild. She decided not to go back to medication. So though her symptoms didn't go away completely, her perspective about having the RLS symptoms changed significantly from the time she originally initiated the treatment, which was, again, based upon going seeing her doctor, talking about RLS, and immediately being put on the Requip without giving her advice about where this could go in the end. So she found that living with a mild degree of soap, she takes hot showers, she does stretching exercises, things like that, which she feels that is just where she wants to be at this point in time, without committing to any particular medications, realizing if somewhere in the future she wants it, there's something out there. But that was her decision. So drug withdrawal for managing augmentation. So in order for me to give you some insight as to the nature of what augmentation is. What is the biochemistry? What's happening to the brain? Why is it that a drug that works so well suddenly comes back and makes things so much worse? So I need to give you a little education about the brain, little neuroscience education. And let's start with the simplest concept. So this is a neuron. This is the cell in your brain. This is the cell body. So this cell body would be have itself parked in the substantia nigra. It makes dopamine and puts them in little packages and transports those packages up the axon, called the axon, up to another part of the brain called the striatum. And it parks those little packages of dopamine in this end here called the presynaptic terminal. Okay, that's where it's stored and it's released. When the neuron has an electrical discharge, it dumps that dopamine into this space between the two cells called the synapse. It can be taken back up into the cell and removed immediately, or it can activate the receptors on the following cell. So that this cell, this surface is called the postsynaptic surface, and that's where the dopamine receptors are. That when you stimulate that receptor with dopamine or with Requip or with Mirapex, it stimulates this cell, and that cell produces another message down the line, and that's the signal. That's the dopamine signal. So the dopamine starts here, parks here, gets transmitted here, and creates the signal in the following cell. So it's very dynamic, okay? So this is a simplified model of what we know about the pathophysiology of the dopamine system in restless leg syndrome, okay? Relative to normal or control populations, studies have demonstrated that, in fact, in the presynaptic or in the cell body of the dopamine cell, there is increased synthesis. Dopamine is being made, it's not decreased, it's actually increased. And what we also see is that not only is it increased, it's also being dumped out in that space, the synapse, the space between the two cells. So you actually have more dopamine out there. That may be because the cell is releasing more, or it is because the cell can't take it up fast enough. So there appears to be two problems. And then on the other side, the other cell, the receiving cell, the postsynaptic cell, the cell with the receptors on it, those receptors appear to be decreased. And the signal from those receptors appears to be decreased. So in the end, even though you have increased dopamine, increased release of dopamine, the signal is being blunted, so you end up with restless leg symptoms. Okay? So I go to my doctor, I say, I have these symptoms, and he puts you on a drug. Okay? So now you have this extra dopamine here, and you have this extra looks like dopamine. This is Requip, this is Mirapex, this is Ritectine. So you double the amount here, stimulates the receptor and gives a double signal. So now your dopamine signal goes up. Great, now your symptoms go away. Everything's great, right? Well, not really. Over time, what happens is that your drug overstimulates these receptors. So you have your drugs overstimulate the receptor, the signal tends to drop, your symptoms start back, it feeds back, and now you are making less dopamine because this signal fed back. You're making less dopamine. The amount of dopamine that you originally had in the synapse has dropped, and now you're left with just mostly the drug doing the work, and the receptors are even less sensitive, and now you got the double whammy. Your RLS starts getting worse. Does it stop there? Unfortunately, it should stop there, but it doesn't stop there. You go back to your doctor and ask for more and more and more. And now you got this picture. You got this big dose of Requip or Mirapex, and it's driving these receptors, and these receptors are feeding back and turning off your own dopamine. Now you're making less dopamine, and there's less dopamine in the synapse. And all you really have there now is the drug. And now your signal is decreased and your RLS is just unbearable. And that is augmentation. So the more complex dynamics, that's a slice through time of the events. That event, the production of your dopamine, the receptor sensitivity to the dopamine and the signal are going to oscillate over the 24-hour period. It'll oscillate based upon your natural circadian rhythms. So this curve that you see here is that dopamine activity. It doesn't state whether that's due to changes in the receptor, changes in production or release. It's the end product. And so what you see is that in the earlier parts of the morning that your dopamine levels are high, the activity is high, your dopamine level. And as the day goes on, your dopamine activity comes down to a nadir late at night during the sleep period. Somewhere around 3 or 4 o'clock in the morning, your dopamine levels go back up again, okay? In RLS, what we believe is that overall production of dopamine sort of drifts downwards, such now that this curve changes. So as the day goes on, the curve drops below a critical level at night. So the amount of dopamine that you ordinarily were making, you're not making now. So this difference between what you should be making and what you're not making is where you have the dopamine deficit, and that's where the symptoms start. And so that's why you get a circadian change in your symptoms, because your natural dopamine will start back up again. So around 3 or 4 in the morning, the symptoms will go away, and you have the protective period. You can rest, you can take a long car ride, you can have your MRI, you can lie in your dentist's office in the morning because your dopamine levels are high. Once you go on medication, everything gets dampened down. Remember, when you go on that drug, what is going to happen is your natural dopamine production is going to go down. So your natural dopamine activity is going to go down. Your natural dopamine production is going to go down. So this curve is going to be driven downwards. So now the curve, the activity curve drops off sooner. Your symptoms start on earlier. The degree of RLS now, the threshold is dropped. So the dose of medication that was working before isn't working as well now. And you can keep adding and adding, and this curve will go down and down and down and down. And there is no bottom. Your symptom comes on earlier and earlier and earlier until you have it 24/7. Augmentation is a result of chronic use of dopamine drugs, with the exception, only one exception, tramadol, which they'll refer to as an opiate, looks like, smells like, it acts like a dopamine agent. But essentially, chronic dopamine use results in a decrease in your brain's natural dopamine levels and activity, and an increase in dependency on the drug itself. I'm sure you can appreciate the magnificent nature of the brain, that it can take these packages of dopamine and deliver it anywhere it wants, anytime it wants, literally within periods of 50 microseconds or 100 microseconds. Yep. And it can be taken, so it is micromanaged down to the microseconds. If you give a dopamine drug, you micromanage nothing. You take a drug at 6 o'clock and that big glob of dopamine is sitting there. The brain doesn't know how to micromanage it, and it clearly has broader effects on dopaminergic function because it can't be micromanaged. And therefore, you are substituting a natural process of dopamine production for a drug that mimics dopamine. And should you be surprised that things go awry? Restoring the natural level of dopamine. So, in the same way that augmentation got you there, by adding the drug, I gave extra amounts and the brain reduced its production. It is, generally speaking, reversible. If I reduce the drug, if I reduce that drug, I obviously will reduce the signal. I'll reduce the amount of apparent dopamine that the brain sees, right? It'll see the deficit. And therefore, it'll go back and start making its own production of dopamine. The problem is there will always be some degree of a lag time from the time you drop off the dopamine to the time you start making sufficient levels of natural dopamine to cover the difference. So the secondary consequence of that is I reduce the drug. It creates the decrement in dopamine activity, and it is synonymous. Decrease in dopamine activity equals increase in RLS symptoms. They are one and the same. You cannot divorce them. You cannot hide them. If you're decreasing the dopamine in your brain, then you are going to get a rebound in symptoms. Anything that prevents you from getting rebound is preventing the first process, the first phase, which is it is not allowing your dopamine activity to reverse itself. Eventually, increased natural dopamine levels will result in improvement in the RLS symptoms, back to what was potentially baseline level of symptoms prior to starting the medication, though in as much as 15 to 20% of people, they will not return to medication, half of which will no longer have symptoms. Okay, so let's talk about the dopamine agonist withdrawal taper with the coverage, without coverage, and I'll discuss that later about the coverage. So I basically taper without coverage. Some of my colleagues will cover with various medications, gabapentin or opiates, and that is their clinical decision making. So basically, I start with the earliest dose sketch, whatever it's. So if they're on, 3 times a day, 2 times a day, I start with the earliest dose within that schedule. The usual incremental reductions is 0.25 milligrams of pramipexole, or 0.5 milligrams of ropinirole, or 1 milligram of the rotigotine as incremental reduction. I usually make the reductions every 3 to 5 days. I usually start out with a schedule that has the reductions every 3 days. But again, there's a lag time between when you drop the medication, the RLS is going to break through. But there may be up to 3, 4, 5, 6, 7 days before your natural dopamine level kicks in enough to counter that decreased availability of dopamine before it counters the drop in medication. The problem is every time you drop the dose of medication, the RLS acts up and you're losing sleep. And if you come to me on 4, 5, 6 milligrams of ropinirole or 4 or 5 milligrams of pramipexole, we're talking about several weeks to get you off. And the longer I take to taper you off the medication, the longer you're going to end up with chronic sleep loss before you even get down to the drug-free period. So that's the balancing act, trying to get you through the taper as quickly as possible in order for you not to already feel depressed about trying to get off. From tapering to drug-free, so there's a tapering period and then there's a drug-free period. So it is a 12-day or 12-night drug-free period. Essentially, 12 days is arbitrary. It is a period of time which seems to be relatively acceptable to patients in that it's not too far out, that they can still perceive it as achievable. If you go out to 2 weeks or beyond, I think initially during the first few days of the drug-free period, it just seems too far out. So I've moved the goalpost around and arrived at a 12-day. So day 1 and 2 often medications. As of all Russell's-like medications, the RLS is as severe as anything that you've ever experienced, unless you've gone off medication before. There will be no sleep, 0 sleep, guaranteed. And then day 3 and 4, RLS is still severe. You might get 1 to 2 hours of sleep somewhere within that day 3 or 4 period, maybe 30 minutes around 7 or 8 in the morning, maybe 30 minutes around 10 o'clock in the morning. During this first 4 days, particularly the second 2 of those 4 days, day 3 and 4, you'll be very sleepy, depressed, anxious. Definitely it's the time you need to take off work during this specific 4-day period of time. Definitely no driving. Day 5 through 8, basically people will be up to between 2 and 4 hours of sleep, completely fragmented. Usually the first, the last 1 to 2 hours of your sleep schedule, you get your best sleep, a few hours broken up in between that. Symptoms will start to roll back. So what might have been morning or afternoon symptoms will start rolling back to late morning or evening symptoms. The symptoms will start to become less intense. The last 4 days, basically, patients are up to between 4 and 6 hours of sleep. Again, usually fragmented, some yes, some no, but usually some degree of fragmentation. The symptoms will roll back to something closer to what they were prior to getting on the medication. And for most people, it's often late evening or bedtime. So they'll roll back to basically bedtime hours. And again, the degree of intensity that started with the initial first 2 days of the drug-free holiday will start to abate. Symptoms may have been the upper extremities. They've left the upper extremities, they're down to the legs. Now 20, 30 minutes of walking helps, while before it was hours of walking. So the intensity that every RLS understands exists, which is often hard to describe, will start to abate. And then there's an evaluation for the RLS status. What are your symptoms? How much sleep loss? These are the treatment options. What do you want to do? And that's where you make your personal decisions about what you want to do next. So, gentlemen had RLS for 30 years, dopamine agonist for 15 years, direct conversion to oxycodone. So this is an example of someone getting drug coverage. So he didn't have to go through the drug withdrawal process. I didn't do it. So currently, when he came to me, he was on oxycodone extended release 40 milligrams, 120 milligrams a day, which is a very, very significant dose. So his ferritin was fine, so that was an option. So we talked about it, and I explained the issues. As far as I was concerned, this patient still had drug-induced augmentation. His symptoms, despite 40 milligrams TID, were still breaking through. Not as bad as they were when he was on the dopamine agonist, but still breaking through now where before it was coverage. And so he went through a detox. In this case, rather than dopamine agonist, he went through the oxycodone withdrawal, which I can tell you was not pleasant. He had severe withdrawal symptoms, not from an opiate point of view. People think about opiate withdrawal with the peripheral and GI. No, it was straight 100% RLS. In fact, he went through the RLS withdrawal symptoms as he should have gone through when he came off the dopamine agonist. As I said before, if you prevent the withdrawal symptom, you prevent the conversion of your brain, altered brain dopamine system, and it lives on just under a different drug. And had I not talked to him and explained it to him, had he done this and gone through, I am sure he would have had a lawsuit against me for making him drug dependent and having to put him through those withdrawal symptoms. He was 18 days off the drugs. I restarted the oxycodone again. He was simply on just 10 milligrams in the early evening and then 20 milligrams at bedtime, and has remained on it without tolerance, without issues. The importance of this case is what I feel is relevant to my decision making as why I do not cover patients during the withdrawal process. This patient came to me in the situation. I had the unfortunate situation where for many years I used to cover patients with methadone and seemed to be relatively successful at doing it. Until one of my patients, after being on just 2.5 milligrams of methadone for just 4 weeks, decided to discontinue the methadone because she didn't want to be on it. She went through horrendous withdrawal symptoms, which should have occurred with the dopamine agonists. And the legal repercussions that resulted from that were very unpleasant for me in my professional career. So I do not, and I'm warning you all to be careful about that decision making about getting coverage. When is the holiday over? Symptoms may continue to improve months and months and months afterwards. I had a patient on 10 milligrams of pramipexole, 10 milligrams of pramipexole. It took me 6 months to get him off. He flew in from California. That's how desperate he was. And he made all subsequent clinic visits via flights in to see me. Most of it was just done over the phone. At the end of that period of time, he basically, at 6 months out, was down to essentially nightly symptoms. He was getting probably 4 good hours of sleep in the last part of sleep, but that's how he just did not want to go back to medications. He had contacted me about 6 months after that, and basically was having symptoms just 2 or 3 nights per week, relatively mild. And I happened to have some interaction with him, actually as part of a research study. He called me to let me know, because he, at that point in time, the symptoms had resolved. He was actually had no symptoms whatsoever at that point in time, and was volunteering for the research study. So the 12-day drug-free period is an arbitrary decision. Some people will continue to go on and have continued improvements weeks and months later. Living drug-free with RLS is a personal decision. Only you can make that choice. Because it is you who live with the symptoms. It is a balance between what you feel you need to do as far as getting a quality of life, as far as the RLS affecting it and the sleep, and what you can personally feel that you can manage as far as living with medications. Remember, once augmented, always augmented. If you go back on that dopamine agonist after even 10 years, your symptoms will rapidly augment again. So if a patient is on a medication that was usually added, so they usually go on a dopamine agonist, the agonist works well for a while, and then it starts breaking through, so drugs get added. Often alpha-2 delta agents, the commonest added drug. It works for a while, it doesn't really work. They sort of keep it on, so it semi-works. So they come to see me. During the detox, everything goes. All the RLS medications goes. When they come back to me, still having symptoms, I will reintroduce that alpha-2 delta agent, because it's not fair to that drug to expect it to do something when that dopamine agonist has a stranglehold on the brain's neurotransmitter system. And so even though it didn't appear to have some value during that period of the augmented situation, often the alpha-2 delta agents will actually have some better activity as monotherapy once you're off. And then obviously trying alternative treatments, in which case, if you haven't tried an alpha-2 agent or haven't tried an opiate, those become the treatment option. So I would point you to the RLS Foundation's brochure. Again, medication withdrawal after augmentation. It's really nicely spelled out. It's something that if you can't get an RLS expert, you should read about it. Take the advice to your doctor. Talk about working with them to see if they can work with you to get off the medication. So when someone says holiday, what do you think of? Something like this? Yep, I'm sure you do. However, a drug holiday, particularly when it comes to augmentation, is more like this, I'm sorry to say. There is dark, dark nights of desperation trying to get through and off these medications. I mean, I for the last 20 years, that's all I do is detox patients off this medication. The best I can say is that for the vast, vast, vast majority of patients to go through the process and get off the medications, though the holiday is not as great as I expected, it usually turns out to be something like this. They will tell you they're happy to be off that medication. They've gotten a large part of their life back, and subsequent decision-making to be on medications, be on alternative medication, usually allows the symptoms to settle out to something that is at least livable and having some level of providing a pleasant quality to their nights and evenings. Thank you.
Wow, Dr. Early, that was an incredible webinar.
Thank you.
But we'll go ahead and start questions. After being on a medication for RLS, will there ever be a time that medication can be weaned and stopped without being miserable?
That may be true for the alpha-2 delta agents and the opiates, but not for the dopamine agonists. Again, you know, I have patients whose symptoms are quite severe and they've been on an opiate or alpha-2 delta agent with really good benefits, and they're on it for years, and sometimes they forget how bad it really is to be off the medication. So I know many of my patients after a number of years will experiment and see if they can reduce the medication. Generally speaking, in my experience, unless there are specific triggers that were antecedent to or complicating the picture of RLS, and they were reversed, then if you don't have that situation, if you don't have the iron deficiency that I treated, if you don't have the antidepressant that you got off of, for the majority of people that I see, their symptoms are unlikely to improve, you know, over the years. But I don't see mild cases. I mean, I rarely don't even see moderate cases. I just see the severe of the severe. So it's quite possible if you had mild symptoms and got on these medications that you could try getting off and might end up being able to have only mild symptoms and decide that, you know, these symptoms maybe aren't so bad, maybe I can live with this, etc. So, but yes, there's always going to be some potential. But again, as I said, you know, the woman that had gone on that trip and ran out of gabapentin, she only had about 2 bad nights. That's all she had, 2 bad nights, and then there was nothing after that. So for her, I suspect the RLS had disappeared a long time ago, so she didn't have any baseline symptoms to go back to that might have made it difficult for her to get off. So.
So are drug holidays effective for dopamine agonists when augmentation has occurred? I know we've talked about this.
Yeah,
and
I mean,
we've had a lot of.
Yeah. Well, you know, it's a drug withdrawal. It's a drug detox rather than a drug holiday. You know, the drug holidays basically making decisions about the 3 items I mentioned to you, which is, do I need to be on it? Do I want to be on it? And am I having side effects? So augmentation is a significant side effect, which is not going to go away without you coming off of it. So.
Okay. Can an opioid therapy be incorporated into the transition of a DA holiday?
It can be, but it's not something I would advise. But have I never used it? It's there. There is about 6-7% of my patients who really balk at getting through the detox process. So I work with them. On a rare occasion, there are a couple small things I can do. Give them an opiate for 1 or 2 nights just to break the severe, just to give a few nights sleep. So that is a tangible, practical approach. Putting someone on an opiate and then getting them off the agonist as a one-to-one exchange is not advisable.
So you're really tailoring it to each person.
Yeah, I mean, I really do. I'm not absolute in anything. I mean, there's certain things I tell you that is majority of what I do, but I do take each case by case and try to give some sense about, you know, is there something little I could do to just get them through this process? So. Right.
Can gabapentin cause symptom exacerbation, and how can I gradually discontinue it?
Yes, in fact, this is interesting. That was an interesting question. Unfortunately, so here's the concept, right? Gabapentin has 2 basic issues. It has an effect on improving your symptoms, okay? But it has sedation. Anything that sedates you or makes you drowsy can make your RLS worse. So you have two competing processes. When you first start gabapentin, as you go up in the dose, sedation, whatever, should be low, and therefore you might get to a dose that works for the RLS without getting sedated. But some people push the medication up. It's working great, say 1,200 milligrams, working great. And then 6 months later, whatever, you develop some tolerance, it's not holding as well, and you might go up on the medication, but you might notice it's a little more sedative. In which case, that sedation actually might start aggravating the RLS symptoms. That's the point, particularly if it's something that you take in the evening. The evening symptoms are going to start popping up. So understanding that there may be that higher dose effect where it may be somewhat negative is important. So your choice is to try to drop back down to a level that was sort of working with it was working 80% here. When I went up, now it's down to 75%. So I reversed the benefits, going back up or trying to find the level that you can achieve with some credible positive effect is doable. Getting off of gabapentin is each doc's going to do his own thing. I usually decrease it by 300 milligrams about every 2 to 3 days until they're off.
Okay. Is it more difficult to take a holiday the longer you've been on a dopamine agonist?
Yes. Some data measuring leg movements and as well as clinical data suggests that the process, that reversible, that dynamic change in dopamine system probably starts within 3 months of getting on an agonist. So even a short period of time on the agonist, getting off, you may really experience some kickback greater than what you expected. However, it is less about time and more about dose. I should say dose is a greater calculation in that. If you've been on a low dose of one of the agonists for a long time, no changes, no nothing, and suddenly it starts getting worse, that's a time to decide to stop. If you go up and up and up, you're just digging yourself a bigger hole to get out of. And so to some degree, the dosing becomes an exponential experience or negative experience. Time does produce something, but it's not clear that whether being on for 3 months or 3 years is going to make a big difference as opposed to being on like 0.5 of ropinirole versus 5 of ropinirole. That's where the difference is. And so, in my practice, I do use the dopamine agonist, but everyone gets, notified of the augmentation. We go through the whole thing. I lay it all out for them. I ask them to read up on the augmentation brochures. I make sure absolutely clear they understand about the issues of augmentation. And they actually sign a little contract with me. So I start them on the dopamine agonists. And in the first 6 months, I'll play with the dose until I get a dose that they're stable on. It's never more than 0.5, usually about 0.125 to 0.25. And then we go with that. After 6 months, if the symptoms get worse, and I think it's augmentation, I will not increase the dose. I may change the dosing time, but I'm not going to increase the dose. They are told that you're augmented, and your choice is stay with the medication until it breaks through sufficiently that they need to make the change or make the change now. So I think at that level, when the augmentation first starts, it's not that bad getting off medications. It's just when you come in to see me and you're on, 4, 5, 6, 8 milligrams, 16 milligrams. Imagine rotigotine, 8 milligrams of rotigotine patch and 8 milligrams of ropinirole. That gentleman took him a year to get off. Anyway.
Wow. Okay, please discuss strategies for coping with RLS symptom escalation during the drug holiday. So what are some strategies that people can do to help get them through this period?
Well, everyone has their own strategy. Again, so long as you're moving, you're all right. It's just you just have to move forever. I mean, you can't even think about lying down, sitting down or anything in those first 4 days off the medications. Some of my patients have had a sculptor, I had a painter, I had a semi-professional pianist. They all basically engaged in something nonstop. One of my patients, threw the husband out, painted the whole inside of her house. Another of my patients brought in one of those dumpsters and did a job in the attic in her basement for 4 or 5 days, just out there in the middle of the night dumping stuff in her dumpster, just staying busy. Outside of that, there's not much else you can do. What you don't want to do is you want to have something lined up. You don't want to be sitting there pacing, counting the seconds. That's not what you want to do. You want to figure out a plan to be able to engage yourself. Even if it's, if you decide you have to go out and go walk around the house 10 million times before you can go back into bed or something like that. But you got to have a plan. And that plan has to be about an activity that you can do during that period of time.
If you go to the RLS and augmentation video, you can just Google it, but Donnie Key talks about what he did, and he had a support network that were like, people were coming in and out of the house, talking to him, doing things. People were driving by with signs motivating him through all of this, because you do hit some lows in this. And we've heard from people at the foundation, what do I do? What do I do? So we've got that, but also this is such a great webinar. We're going to post it on the website. We're also going to have it in our social media with the handout that Dr. Early showed you, so that everyone can have access to this information.
Yeah, I agree that emotionally supporting people, spouses, friends. I have a list of patients who have agreed to contact my patients going through that process, and so they become a supporting person. Obviously, there are a lot of support groups online out there of a supporting person who has been there and has done that, because they speak the language of the person that's in the process of suffering with this detoxification process.
Right, and we have people, support group leaders who've done that as well. So we're able to get you in touch with people as to help get you through this, if you choose to go that route. What are considerations in deciding the timing of when to start and go through a drug holiday or medication change?
Availability, personal availability. It's a timeline. As you can see, there will be weeks or so to taper, and then obviously close to 2 weeks off the medications. There'll be a period of time in which you have to get back on something. You don't want to do this at Christmas or Thanksgiving. You don't do it during holidays. So it's if you got to be physically active, if part of your activity is going to be outside, you don't want to be doing it in the dead of winter. So those are personal decisions making, trying to find the block of time that you can commit, because once you start, you want to go straight. You don't want to pull up short in the middle of this. It's just not where you want to be, I think, in the long run.
And don't do it on your own, because we've had people do this over a holiday weekend without a physician supervising it, and they get into serious trouble. So, you really have to plan this event out, as Dr. Early said, and think it through, and know what you're, each step of the way, how you're going to manage this and what activities you're going to do. You have to have it planned out, because when you're going through it, you're not going to think like, okay, now I can do this, or I could do something else to keep yourself engaged. Right. And so, Dr. Hurley, before we finish up, we always have to ask you what research you're working on with RLS.
Actually, I was gifted with a endowed sleep or RLS research grant, which will provide me with support to hire, and I have a new RLS research. She will be doing basic research. So we are looking at utilizing a couple of what we developed over these years, animal models, to try to understand the basic neurochemical issues, and hopefully, and we have the models actually have piloted 2 studies with existing medications, which have been proved to be some value, but we hopefully can get more higher quality, nuanced drugs out of these models, and that's what she's going to be working on. I am doing some what's called epigenetic work, trying to understand the nature of genes, or at least the mechanisms that are underlying what turns genes on, what turns genes off. Not the genes themselves, but what in your body at any given time in life turns them on or turns them off. And those are called epigenetic processes. They are often open to environmental changes. So things like iron deficiency can cause these little tags to be added to your genes, which will sometimes turn genes on and sometimes turn genes off. The question is that causative? Does pregnancy, does iron deficiency early in life or in utero cause some of these epigenetic changes that put you at risk of developing RLS in your future? So I'm looking for some of those tags, as we call them, to see if I can identify anything that could give me some relevance as to where in the genetic system it's operating, and obviously pushing that out to understanding it's those genes in terms of brain chemistry.
That's exciting to all of us whose families are affected by RLS, and we thank you for all your work. And now you know why Dr. Early is one of the most sought out speakers at SLEEP. I've stood in line out in the hallway hearing everyone scream as to why they should be in that room hearing Chris Early speak. So we look forward to all that you have to offer to our community, and I can't wait to see you at SLEEP, because you always have the best slides ever.
Well, thank you, everyone. I appreciate all those who've attended. I hope it's been of value. I hope it's been of value too, because I think it's an important subject. So thank you all.
All right. Thank you, Dr. Early. Have a great weekend.
Same to you all.
Bye-bye.